Hello, I'm Ash Patel. I'm a consultant vascular surgeon at Guy's and St Thomas's Hospital in London in the UK.
And I'm Narayanan Thulasidasan. I'm an interventional radiologist, also at Guy's and St Thomas's in London, UK.
So, NT, we treat a lot of patients with CLTI. It's endemic at the moment in the UK and Europe. A large proportion of our practice is based on treatment of these patients. I feel that we have the devices for iliac and fem-pop interventions, but what are your thoughts on the BTK space and the devices that we have available?
Well, it's a huge part of our work, isn't it? And I think not only BTK, but the combination of diabetes and chronic kidney disease really leads to a high prevalence of heavily calcified below the knee disease in these patients. And let's be honest, that's where the real legs are saved, is in below knee work. Patients with tissue loss, direct to the wound revascularization. And it's just important to note that we, as you said, we've had a lot of devices released for the fem-pop segment over the years, but we find ourselves still using plain balloon angioplasty as the mainstay below the knee for a long time.
And your thoughts on patients who have disease below the ankle? Do you have devices for those lesions?
Yeah, and I think it's become increasingly clear over the last few years that revascularizing the inflow isn't always enough for these patients with open wounds, that you actually really need to get flow directly out to the wound. And as that realization has increased within the vascular community, we've started to venture below the ankle more and more often.
Yeah, it's a notion of straight line flow.
Absolutely.
So as you know, we have an MDT approach to these patients. Some patients have bypass surgery, distal bypasses, but we know from the latest data that there's equipoise now, and especially the frailer patients who may benefit from endovascular technologies. And therefore, we need to make sure that we use the right devices and have the appropriate device available to us. So we have cases where the wire passes, but then your device won't cross. What sort of strategies do you adopt in your practice for these sorts of cases?
So we've experimented with some vessel prep devices. We've experimented with rotational atherectomy and orbital atherectomy. These devices are expensive and they do come with risk. Right, so they're bulky devices, you're modifying plaque, but you're also cutting, shaving plaque. There's a risk of distal embolization, slow flow phenomenon. In terms of delivering these bulkier devices down in the distal below the knee circulation and below the ankle particularly, there's often difficulty delivering the devices themselves. You may need to deliver them over a through and through wire, so you need to get a retrograde access simply to deliver a device. So yes, they can be effective, but they come at a cost, both in terms of ease of use and safety, which is the crucial thing here.
Are the techniques that you mentioned earlier similar for below the ankle?
So I think once you get below the ankle, suddenly your retrograde options either disappear or become significantly technically more difficult when we're talking about puncturing vessels retrograde in the midfoot or in the forefoot. That is a level of technical ability that I appreciate that not everyone will be able to attain to, and not all patients will give you the option to be able to do that. The tortuosity is an issue. There are at least two sharp turns in every patient who you're treating below the ankle disease as you go around the pedal arch, and delivering, as I said, bulkier devices through this kind of anatomy is a challenge.
Let's go on to our case. So this lady presented to my clinic. She's 70 years old. She presented with a 3-month history of gangrene of her left hallux and really severe rest pain. She wasn't sleeping at night, wasn't coping at all at home. She's a smoker and continues to smoke, and she also has hypertension, which is well treated. You can see from the images here, she has dry gangrene of the distal phalanx of her left hallux. So, NT, as you know, we treated her fem-pop disease. We knew on the duplex scan she had some fem-pop disease. So she had a plain old balloon angioplasty and then a DCB for that lesion. But now here's the angiogram of the vessels below her knee. So what are your thoughts on the angiogram here?
So she's definitely got trivessel tibial disease. We can see multifocal stenosis in the posterior tibial artery. But I'd also draw your attention to the fact that the drainage of contrast is slow because of an impaired outflow. So as we go down to look into the pedal circulation, maybe you can see that actually the flow is really slow here because we've got significant pedal disease. You can see the lateral plantar artery is heavily diseased. You can only pick out a dorsalis pedis for the first inch or two in the foot, and that really tallies with the fact that she's got this necrotic hallux.
And she has CLTI, and the key here is she needs straight line flow. So we are focusing now on on her disease below the knee and below the ankle.
Absolutely. So that hallux is going to need to come off, right? And we need to make sure that the wound bed has direct flow to it to allow that to heal. So initially, the only treatment we had to offer these patients was balloon angioplasty. You know, with atherectomy, you're always worried about distal trash. So we would go with balloon angioplasty, maybe focal high pressure balloon angioplasty in areas that didn't respond. And if we had a flow limiting dissection, then at some units, but I appreciate this is not available everywhere, we would use bailout drug eluting stenting. But we can't just look at the tibials in isolation. We also have to look into the foot. And as you've already shown, there's significant pedal artery disease. In the setting of heavy calcification, we've been using balloon-based IVL strategies, which have worked very well in the tibials, particularly with some of the newer technologies that are available. But as you get into the foot, trackability does become an issue when you have to deliver these devices down into the distal lateral plantar artery, distal dorsalis pedis. So we were lucky enough to be involved in the limited market release of the Javelin IVL catheter. And I think this case presented itself as a good option for that, where we've got a few focal lesions in the posterior tibial artery that we need to modify and treat, but we also need something ideally with the same device that we can move into the foot and use to treat that pedal disease with equal effectiveness and a sort of a guarantee of trackability of being able to deliver the device to where we need to treat.
So the wire passed through the posterior tibial artery, and then we chose to use a Javelin.
Yeah, so we used the Javelin in the posterior tibial artery, and this is where I'd sort of throw the question back to you, really. This is a new device. Do you have any tips that you would say to optimize the use of the device and really get the most out of it, given that this is going to be something new for most people?
It's quite different to the traditional IVL balloon-based devices that we have. With the Javelin, there's 120 pulses, and the key here is to maintain forward pressure whilst you're pulsing. So here's what we've just done with the Javelin, where we maintain the forward pressure to advance it toward the ankle. The other benefit of the device is you can take the wire out and use it to carry out an angiogram. So here's the angiogram, which is a super selective angiogram of the vessels below the ankle. What are your thoughts on the foot arch here and the lateral plantar vessels?
So you can see on this angiogram there is multifocal tight stenotic disease all the way through the distal posterior tibial artery and well into the lateral plantar artery. And this is where the Achilles heel of these below the ankle interventions up until now has been, is that when you treat these kind of lesions, you might get a good result for the first few minutes, but we know that up to 50% of these lesions will recoil significantly within the first few hours following your treatment. So we're looking to leverage those benefits we've seen using balloon-based IVL in other vessel beds to kind of give that durability in these kind of heavily calcified stenotic lesions that we're seeing here.
But our problem here is that a balloon-based IVL may not track, or any other balloon may not track. So we haven't got the option here to prepare the vessel adequately.
And I think that's where we saw the use for Javelin in this case, is that something that we could rely on the deliverability to take it all the way out into the distal lateral plantar artery.
So talk us through the use of the Javelin in the lateral plantar vessel here.
So here we had a wire around the pedal arch. It was not easy to cross completely, but eventually we were able to get a wire around the arch. And then again, we were using that technique, pulsing while applying forward pressure in areas of resistance and taking the Javelin catheter through the lateral plantar artery. And actually, as you can see on these images, it tracked all the way around the pedal arch, pulsing where necessary to make sure that it could get through. So once we've taken the Javelin around the pedal arch and modified that calcium in those areas of high stenosis, what did we do next?
So what was really impressive here was how before, when the catheter wouldn't pass around the foot arch, the POBA has now tracked really easily because the vessel has now been modified and is much more compliant. So the patient had an angioplasty of the foot arch with a 2mm POBA, and we also treated the rest of the posterior tibial artery all the way up to the origin. We've also then gone and treated the anterior tibial artery right down to the foot and the dorsalis pedis. So NT, here's the angiogram at that point. What are your thoughts here?
So we have that little bit of focal spasm at the posterior tibial artery bifurcation, and I remember we went back to this and treated it with some local nitrate instillation and a low pressure 2mm balloon angioplasty just focally. But what was really impressive was the way a knuckled wire just flew around the pedal arch after the Javelin treatment, that there was no resistance at all, and that really gives you that confidence that you've opened that vessel with with great luminal gain and some durability that we can now impart to this. The wire didn't stick at all.
What was also impressive was how the IVUS catheter also sort of flew around the foot arch, which when it wasn't passing at the beginning. And you can also see now in the IVUS images how there's pulsatility in there and the compliance in the vessel, which we didn't see before.
I think these IVUS images are really telling that that historically the advantage of vein bypass over endovascular treatment has been that ability to transmit pulsatility right out to the distality of the foot. And now by changing the compliance of the pedal arteries with IVL, we're able to repeat the same trick with an endovascular therapy.
And your final thoughts on the angiograms?
Yeah, so we've got this really nice large bore lateral plantar artery open all the way into the foot, and you can see inline flow into that first metatarsal artery that's filling really well, and we gave us that confidence really to take off the toe at the same sitting, knowing that our endovascular treatment is going to stay open long enough for that amputation site to heal.
And that wound had pulsatile bleeding, as you saw on the operating table, and we left the wound open to heal by second intention. As you can see from the images, she had healed very rapidly and she is now fully healed. And I wouldn't expect that kind of wound to heal so quickly with a patient with multi-level disease if we hadn't treated the lateral plantar so effectively.
I think that shows the benefit of establishing inline flow directly to a wound bed, that you get this kind of rapid healing. And before, we didn't have the devices to provide this kind of distal revascularization. So it's really exciting to be around when these devices are coming into our armamentarium to allow us to achieve results like this.
So Anthony, that was a great case. Where do you see the Javelin device being used in your practice?
I think there are going to be a couple of major applications. I think the first is going to be in the below knee segment, where you can't track a balloon or a crossing catheter and you need something to be able to modify these tight focal calcific stenosis that prevent device delivery. I think the other area where I think particularly both you and I are going to find this very useful is in below the ankle. It's where you don't have the option to do a retrograde access to be able to help pull a device through a lesion, where you have to work without that kind of pushability. Having the ability to modify a lesion with forward IVL is going to be really valuable when you get into the pedal arch and trying to get these really wound-directed revascularizations.
Agree. It's a device to have on your shelf.
Absolutely.